Positioning lesson 4 covers the elbow and humerus. The elbow is one of the most complex joints in the body to image because of the number of structures converging at a small area, and because pediatric elbows require knowledge of the CRITOE ossification sequence. 12 minutes. AP elbow. Patient seated at the end of the table, arm fully extended, palms supinated, facing up. The full supination externally rotates the forearm, placing the elbow in a true AP orientation with both epicondyles visible in profile. The arm and forearm must be on the same horizontal plane. If the shoulder is elevated, the elbow tilts. Ishi 40 inches. KVP 60-70. Nogadith. CR. Perpendicular, centered to the elbow joint midpoint. Must include distal humerus and proximal forearm. Evaluation criteria for the AP. Both epicondyles visible in profile on the medial and lateral sides. The radial head and neck slightly overlap the proximal ulna. This is normal. Elbow joint space open, no foreshortening. Radius and ulna not superimposed at the shaft level. Soft tissue visible on both sides. Trauma AP, partial extension. If the patient cannot fully extend the elbow due to pain or injury, never force it. Take 2 separate partial extension images. View 1. The forearm flat on the IR. Images the distal humerus clearly. View 2. The humerus flat on the IR. Images the proximal forearm clearly. Document partial extension on each image. Lateral elbow. Elbow flex to exactly 90 degrees, not 85, not 95. Exactly 90 degrees. The thumb side up, true lateral. CR, perpendicular to the lateral epicondyle. Evaluation, the fat pads. The anterior fat pad is a small triangular lucency anterior to the distal humerus, visible in small amounts on a normal lateral and normal. The posterior fat pad normally sits hidden in the olecranon fossa. Any visible posterior fat pad is abnormal. It means joint effusion or hemarthrosis has displaced it posteriorly. In the setting of trauma, visible posterior fat pad equals occult fracture until proven otherwise. The Sale sign, the anterior fat pad elevated and prominent in a triangular sail shape, also abnormal when prominent. Olecranon in profile. 3 concentric arcs visible at the humeroradial articulation. This is the normal appearance of the capitulum, trochlea, and radial head overlapping in a true lateral. 2 oblique projections. Medial oblique, internal rotation 45 degrees, places the coronoid process in profile and demonstrates the medial epicondyle. Lateral oblique, external rotation 45 degrees, places the radial head and neck in profile without ulna overlap. AP humerus. Arm extended, elbow slightly flexed. Palm supinated, external rotation of the entire limb. This places the greater tuberosity in profile on the lateral aspect of the humeral head. CR. Perpendicular to mid-humeral shaft. Ishi 40 inches. KVP 60-70. Must include the entire humerus, glenohumeral joint to elbow joint, on one image. Both joints visible. Lateral Humerus. Internal rotation of the arm, palm facing posterior. The small tuberosity comes into profile on the medial side. CR. Perpendicular to mid-humeral shaft. True lateral. Medial and lateral epicondyles superimposed. Common fractures. Radial head. The most common adult elbow fracture. Mechanism. Fush. Frequently occult. The posterior fat pad sign is the radiographic clue to an invisible fracture. Supracondylar. The most common pediatric elbow fracture. The anterior humeral line, drawn along the anterior cortex of the humerus on a lateral, should pass through the middle third of the capitulum. If it passes through the anterior third or misses it entirely, the capitulum is posteriorly displaced, supracondylar fracture. Olecranon, direct blow, gap visible on lateral. Montagia, ulnar shaft fracture with radial head dislocation. CRITOE, the mnemonic for the order in which the 6 elbow ossification centers appear. The registry tests this sequence directly. C. Capitulum, 1 year. First to appear. Always visible by age 1. R. Radial head, 3 years. I. Internal, medial, epicondyle, 5 years. This is the most commonly avulsed ossification center. It is pulled by the flexor muscle group with valgus stress. T. Trochlea, 7 years. Critical rule. The trochlea should never appear before the medial epicondyle. If you see a trochlear ossification center without a medial epicondyle, the medial epicondyle has been avulsed and may have migrated into the joint, mimicking the trochlea. O. Olecranon, 9 years. The large posterior apophysis. E. External, lateral, epicondyle, 11 years. Last to ossify. Smallest center. CRITOE, 1, 3, 5, 7, 9, 11. Apply this sequence to every pediatric elbow, and you will never miss a displaced medial epicondyle. 3 elbow and humerus questions. The answer is B. Indicates joint effusion or hemarthrosis. Treat as occult fracture. Any visible posterior fat pad on a lateral elbow radiograph is abnormal. The posterior fat pad is normally hidden in the olecranon fossa and invisible. Effusion or hemarthrosis from a fracture displaces it posteriorly into view. In the setting of trauma, visible posterior fat pad equals occult fracture until proven otherwise, most commonly a radial head fracture. Treat accordingly even if no fracture line is visible. The answer is B. Possible avulsion of the medial epicondyle, which may be in the joint. CRITOE tells us the medial, internal, epicondyle at age 5 always appears before the trochlea at age 7. If the trochlea is visible without a medial epicondyle center, that apparent ossification in the joint space may actually be the avulsed medial epicondyle, which has migrated into the joint. This is a classic pediatric elbow pitfall. The answer is B. Supinated, palm facing up. Supination externally rotates the entire upper limb, placing the greater tuberosity and profile on the lateral side of the humeral head, a true AP view of the humerus. For the lateral humerus, the arm is internally rotated, palm facing posterior, placing the small tuberosity in medial profile. Lesson 4 complete. You covered AP elbow positioning with the partial extension trauma protocol, lateral elbow with the posterior fat pad sign and the Sales sign, medial and lateral oblique projections, AP and lateral humerus, common fractures including radial head, supracondylar, olecranon, and montagia, and the complete CRITOE ossification sequence. Know the fat pad sign and know CRITOE. Both are tested directly.